Okay. All right, we'll go ahead and get started. This is a primer on retinopathy of prematurity. I cover this talk every couple of years. I've updated it a couple of times. It's very unusual and rare these days to actually do ROP as part of your pediatric or retina practice. I think over 90% of retina and pediatric ophthalmologists or retina surgeons do not do ROP, and I think probably a minority of pediatric ophthalmologists do ROP screening and treatment. It's important to know about. It's probably the single most efficient reduction of blindness or severe vision loss in all of ophthalmology because of the utility you get when you preserve vision in a premature baby for 60, 70, 80, 90 years. So it's very impactful from a treatment standpoint. And from a career and practice building standpoint, it's a wonderful skill set to have because it's in very high demand since there's such a low supply of people who do it and a continued production of premature babies. So if you're thinking about going into practice somewhere and you want to add value to yourself, learn to do ROP and be comfortable with it. Thirdly, it is chronically on your board certification. You will definitely see ROP questions on your board certification. So the primary purpose of our didactic lectures is, of course, to make you competent clinicians. Immediately behind that is for you all to pass the board at 100% the first time, which we know is unlikely to happen, but these lectures are supposed to improve your chances. All right, good. So retinopathy of prematurity. This is the anatomy of retinopathy of prematurity. And there are three ways that you classify retinopathy of prematurity. It's by location, extent, and severity. Location goes from posterior to anterior, and it's typically written in the Roman numerals 1, 2, and 3. And it's zone 1 is the most posterior, which is an area centered around the optic nerve. Zone 2 goes from the nasal ora serrata in a perfect circle temporally, and zone 3 is the temporal crescent temporal to that zone 2. So you describe your ROP by location. How posterior is it? Number 2 is extent in clock hours. That's super easy. You just count 1 to 12 clock hours. And then stage. The stages are in Arabic numerals 1 through 5, 1, 2, 3, 4, 5. Hopefully you don't ever have to document, and with appropriate screening, you almost never have to document a stage 4 total RD. It gets exceedingly rare in the modern era, as long as the babies get their visits and the doctors can appropriately examine the patients. It happens, but it's fortunately become rarer and rarer and rarer. Plus disease is a characteristic you see, and you can describe that separately from location, extent, and severity. And I'll show you some photographic examples of that. That's dilation and tortuosity of retinal vessels. So it's a really easy classification system, but it gets confusing a little bit over time because there are so many numbers involved with it. You just got to use it and you'll get used to it. Location, extent, and severity. Okay, the Cryotherapy study was the first randomized controlled trial in retinopathy of prematurity. It looked at almost 10,000 infants who were small with birth weights less than 1,251 grams. And it defined threshold ROP, which we'll get into. This is ancient history now, from over 2 generations ago, and half the eyes were treated with cryotherapy to ablate or cryofreeze the avascular retina, the anterior retina, and half were left as untreated controls. Unfavorable outcomes, of course, were retinal folds, posterior detachments, retrolental tissue, and they used to call ROP retrolental fibroplasia because the retina becomes a closed funnel right behind your lens. I mean, this is like blindness, NLP blindness when things go badly in untreated and kind of old-fashioned ROP treatments. Threshold disease was defined in the Cryotherapy trial, and it's extremely important to memorize what this is because this is a guaranteed question on your written boards. Even in the modern era where we use other criteria that I'll get into in addition to threshold disease. Threshold disease, and burn this phrase into your minds, screenshot this, look it up in your books. It's 5 contiguous or 8 non-contiguous clock hours of stage 3 retinopathy in zones 1 or 2 in the presence of plus disease. So location, zone 1 or 2, extent, 5 contiguous or 8 non-contiguous clock hours, severity, stage 3, presence of plus disease. Location, extent, severity. You will get a question on this. This can be the question that passes your board exam for you, even if you never successfully see the retina in a premature baby in training or in practice. Important definition. If you look at the pictures on the bottom left shows the 8 non-contiguous clock hours of stage 3 in zone 2, and the picture on the right shows the 5 contiguous clock hours of stage 3 in zone 2. Both of those are threshold ROP, and both of those triggered treatment in cryo-ROP and still trigger treatment in the post-cryo era, which we've been in for over probably 20, 30 years now. This is plus disease. On the left side is the standard photo of plus disease from the cryo-ROP study. It's tortuous and dilated posterior vessels. More nuanced modern interpretations of plus look at it in quadrants, but traditionally, and for the purposes of this lecture and your learning as general ophthalmology residents, plus disease is posterior dilation and tortuosity. The photo on the right is a montage that shows the plus disease, which of course is not isolated to the posterior retina, but extends peripherally as well. But that's what plus disease looks like. ROP is very visual. It's pattern recognition. Once you get good at it, it's very easy to see what normal versus abnormal looks like. So what happened in cryo-ROP? Well, outcomes were bad all around, but they were better when patients were treated with the cryo. When patients were treated with the cryo, only a quarter of them had unfavorable outcomes, meaning these horrible detachments and NLP vision, basically. If you look at the treated eyes, they did relatively well. The untreated eyes, about half of them had these terrible detachments and essentially non-functional vision. And ROP is a symmetric bilateral disease in most patients. So this in the real world is something you would look at both eyes. Those are unacceptably poor outcomes. So this is the last study that ever looked at untreated ROP. And in untreated threshold ROP, half the eyes essentially go blind to the point of non-functional vision. So the important thing about cryo-ROP is not to memorize that cryo works, it's to just teach you how bad this disease is. It's a really, really, really bad disease. The early treatment for retinopathy of prematurity study, the ETROP study, looked at a different treatment modality. This looked at high-risk pre-threshold ROP, and it looked at early treatment, but importantly, it looked at laser treatment. What this showed is that when you treat kind of pre-threshold ROP, which is a slightly different criteria than threshold, which you don't have to memorize, you had a significant reduction in the unfavorable outcome. So treating a little earlier, the point of this study is treating a little earlier is probably better than treating a little later. Of course, it's best to treat just right, like your porridge. It's best to have your porridge when it's just right, but it's very important to not treat too late in retinopathy of prematurity. Treating ROP is kind of like taking out appendices. You're not going to take out 100% pathologic appendices, but if you take out the appendix too late, you wind up with peritonitis and an ICU patient who's dying. If you treat 100 ROP patients and you treat 5 or 10 of them too early, and you have 100 patients who can see, it's better than having 5 or 10 patients who have NLP blindness. So early treatment's probably a little bit better. ETROP also looked at laser. Laser is still the mainstay of treatment. Laser is still the gold standard of treatment in 2021, even though anti-angiogenics have revolutionized our treatment. And some centers do them exclusively, some centers mix them with laser. I don't think there are any centers that don't do them at all anymore, but laser is still the gold standard. And laser is not like PRP laser for a diabetic. Laser is different. The picture on the left shows appropriate laser burns for treating a patient with threshold ROP, of confluent laser spots. Reed Pavin, may his memory be a blessing with his beard. He's not gone in that sense, but he's gone from academic teaching, and that makes me sad because I really love working with Dr. Pavin. He used to say that you have to lay waste to the retina in ROP. I did do treatment with him as a trainee, and that it is napalm to the retina. On the picture on the right shows what this looks like when the laser is mature. The picture on the right shows that the laser spots are confluent and they're absolutely complete. This is not the modified ROP, the modified PRP that some people do in clinic. This is confluent white spots. And that's going into a patient that was having disease clearly in zone 2. So we'll get into a little bit of the laser versus bevacizumab or Avastin for ROP. And ranibizumab is currently under study. There's publications looking at all of the anti-angiogenics in ROP, but the best data to look back on, since this data is beginning to age, is the BEAT-ROP study, which looked at bevacizumab versus laser. This looked at 150 cases of posterior ROP. Posterior disease is the worst disease, zone 1 disease, posterior zone 2 disease. And it looked at the bevacizumab injections versus laser. And it compared these patients 50-50. What we saw in the first retrospective review of these patients is that the traditional laser treatment in these posterior patients, some of this is too technical for the purposes of this lecture, is that the BEAT-ROP study showed that the posterior patients actually did better with the bevacizumab treatment than the laser treatment anatomically. The anterior cases still responded well to laser. The posterior cases responded better to bevacizumab. And that was a very important thing that changed how we treat. It also taught us, and we'll look into this a little bit more, that follow-up of the patients who received treatment with bevacizumab is different than treatment with laser. One of the biggest problems with treating retinopathy of prematurity patients is it's very hard to get many of them to follow up. They won't come back, or they can't come back, or things happen socially, they get adopted, they get moved out of state, they moved 5 counties away, and it's very hard for them for a variety of reasons to come back to clinic. And what we learned from BEAT-ROP is that follow-up is required until the retinal vessels reach the ora serrata, because you can get recurrences at a high rate when the retina is avascular anteriorly and there is no laser there, even several months following the treatment with the Avastin. The regression patterns, and this is what I was hoping that you guys had seen some pre and post treatment patients for, is the regression patterns with intravitreal bevacizumab with Avastin are profound. The looking at a small retrospective review showed that the patients had a profound and rapid regression with injected with Avastin, and the dose is very small in these patients. It's half of the adult dose. It's 0.025 milliliters or 0.625 milligrams. And looking at that as first-line therapy causes rapid regression patterns in patients with pre-threshold and threshold ROP. Even 48 hours following the injections, you see a profound improvement. What's interesting is even though you do get this profound improvement, you see an absence of vascular maturation. You see the vessels get better quickly and their maturation is simultaneously stunted until several weeks after injection. And even many, many months after injection, a good proportion of patients have persistent anterior non-perfusion. And we know that some of those patients reactivate. So when those patients reactivate and have proliferation and retinal detachment, it happens much later than the patients who reactivate after laser. If you do laser and the patients don't respond, which takes much longer, the response time is much longer than when you're doing the anti-angiogenic injections. It's like in any proliferative retinopathy, the laser takes some time to work. If it's going to fail, it completely fails relatively quickly. Then you can do something else. In the old days, you would do vitrectomy. In the modern era, you often do a anti-angiogenic following your laser. The failure of the anti-angiogenics is much later in the ROP patient. So they just have to be followed closer and follow longer. The response is different, and that's the point of what I'm talking about. And this is something that you probably won't be able to appreciate in your short time in the ROP clinic unless you follow, do you guys see patients in an outpatient ROP setting? Do you ever examine patients who come back?
Sometimes they show up in clinic, but I don't think that's that common. I don't know. Maybe Jason can touch up on how many ROP injections and stuff they've done or he sees in Balia's clinic.
Most of them follow up in Dr. Nakanishi's clinic.
You guys rotate through Dr. Nakanishi's clinic in pediatrics?
Yeah, we have a couple weeks with her.
So do you see any ROP babies for follow-up?
I don't know. I personally probably, from being in her clinic, was probably like in a span of like 6 weeks, maybe like 5 or 6 ROP exams that whole time.
Yeah, they don't follow up. Their follow-up rate is probably very low for the variety of social, economic, and logistical reasons. And still, most of them aren't going to have a recurrence of retinopathy of prematurity or recurrence of proliferation. The recurrence rate in most of these trials of bevacizumab as monotherapy is around 15 to 20%. So it's still relatively low, but your recurrence rate following effective laser is fractional. It's in the order of approaching less than 1 or 2%. So you just have to watch them for recurrence if you're going to rely on anti-angiogenic monotherapy. The adverse event profile is something that is still evolving. The anti-angiogenics do have a systemic distribution, and you have to look at both the local adverse effect rate, which can include infection, iatrogenic cataract with anti-angiogenic injections. Those two complications have an extremely low rate. But if you look at the follow-up of these patients systemically, you wonder if the anti-angiogenics are further affecting their already high risk for developmental problems, especially neurodevelopmental problems related to the anti-angiogenic injection. The problem with these studies is follow-up was initially limited, but they've gotten longer. I don't have a slide in here on it, but the BROP patients are followed for over a decade now. And what we learn is even though there are local adverse events and the systemic adverse events following the injection of anti-angiogenic in these children, the actual difference in the BROP study patients followed out for a decade does not show that you're exposing these patients to a higher risk of adverse events systemically than you would with laser. It's probably an equally safe treatment systemically to laser, but you know, the longest follow-up is something about a decade, 10, 12 years. So we don't know absolutely for sure. And if you're consenting a patient and the parents ask, do we know how this will affect the child for the rest of its life? The answer is, of course not, because we haven't been doing this for 30, 40, 70, 80 years. But it's getting more and more probable, and you can tell them that there's more and more evidence that the intravitreal anti-angiogenic injection is exceedingly safe systemically. And that's the point of these slides, is that the use of the intravitreal Avastin appears to be safe for type 1 pre-threshold and threshold ROP. The vascular changes following anti-angiogenic therapy continue to be characterized. Wide field photographs and fluorescein angiography before and after treatment show the area of the retina that is avascular and remains avascular. Do you guys have wide field photography at Tampa General?
No imaging systems at TGH, just our indirects.
Yeah, no imaging systems at all children's either. If you look at the thought leaders on ROP, all of them have beautiful imaging systems. I would love to have an imaging system. The case made for them is difficult for hospitals that don't have a strong focus on ROP because they are expensive and they require technical staff time. So it's unfortunate that neither of us have these imaging systems. In Miami, they have a beautiful imaging system for the NICU and for the operating room for angiography and fundus photography. But the avascular anterior retina is something that you see before and after the anti-angiogenic treatment. You can also see it, of course, on your indirects. You can see it when you're looking, but it's striking how the retina remains avascular following the anti-angiogenic therapy. There are a couple of small studies that look at comparisons between bevacizumab and laser, and the point of these slides is that there is a compendium of data that's coming together, retrospective data, prospective data, short-term data, long-term data, and in general, there's more and more evidence that using the anti-angiogenics is reasonable, but you got to follow the patients over time. I think that's my last slide here, but I wanted to answer any questions that you have about treating ROP and about working on these children, about what you'd like to know about treatment, about what you don't know about treatment, what it's like to do it in the real world. I've followed these kids at All Children's for over a decade.
There's a variability in where people go posterior to the limbus during injections. Where do you go, Dr. Eichenbaum?
It's a great question. I go 1 to 2 back in these kids. It's because they have very flat posterior lenses, and there's very low risk of causing an iatrogenic cataract. When they're less than 3 months old, you can probably go about 1.5 back. Truth is, with these kids with completely intact hyaloids, you can probably put a 30 gauge or 33 gauge needle pretty much anywhere and not cause a detachment. It's probably the truth about it. But the pars plana is probably about 1 to 2 back. Where do you guys go back?
We do 1.5.
Yeah, so we're all in the same ballpark. And you just like doing your adult intravitreal injections, wherever you go, you want to aim for the optic nerve. You don't want to scoot anteriorly. I have not seen an iatrogenic cataract in these kids yet, which is, of course, fortunate, and it means we're probably going in the right places. Do you guys see iatrogenic cataract?
So far, I haven't seen any.
Good, that's awesome. The only time I ever had an iatrogenic cataract was actually from a laser treatment. You can cause anterior segment ischemia, which is one of the complications of the laser. And when you cause anterior segment ischemia, you can have a rapid onset ischemic cataract. And I did have in treatment one child many years ago who developed a unilateral ischemic cataract, which was interesting. A very sick patient. I think the patient succumbed to complications of prematurity sometime after that. Well, thanks everybody. I appreciate it. I'm going to pop off to go to an 8 o'clock investigators meeting, and I appreciate the opportunity to present ROP to you. Please remember that the takeaways are threshold disease and beat ROP. Those are the 2 things that are going to be on your boards. All right, guys, have a great rest of your morning.